Welcome, everyone. We'll wait a few moments for everyone to join us. Welcome to the National Multi-sectoral Platforms Breakout. I would like to introduce our speakers. First, we have Sid Chatterjee, the UN Resident Coordinator for Kenya. And joining him is Jan Willem Scheijgrond, the Vice President, Global Head of Government and Public Affairs for Royal Philips. Gentlemen, would you like to begin?
Are you asking?
Hello.
Hi. So do we get started, Barbara?
Thank you. Yes, let's go ahead and get started.
Okay, fantastic. So let me start with a famous Greek philosopher called Herophilus. He said that when health is absent, wisdom cannot reveal itself, art cannot manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. So essentially what we are seeing in this current unprecedented global health crisis, which is affecting all parts of society and changing lives and damaging livelihoods, there is attention being focused most immediately on those affected by the virus, but there are many indications that the COVID-19 pandemic will have long-lasting social, cultural, economic, political, and multidimensional impacts on all of society. And therefore, this brings back into focus a renaissance, which we saw in the 15th century with Martin Luther, from Catholicism to Protestant movements. We are going to see a renewal of multilateralism through a very important aspect, which is public-private partnerships, which will be going ahead to flatten the curve. And like the UN Secretary General has said, that it is a very defining moment in our society. History will judge the efficacy of the response not by the actions of any single set of government actors taken in isolation, but by the degree to which the response is coordinated globally across all sectors for the benefit of all of humanity. And therefore, governments, as it has been often said, this is an all of society response. The private sector, the development institutions need to come together in innovative ways, not only just to flatten the curve of infection and mitigate the economic disruption, but also to prepare for the new normal, which is the post-COVID environment in Africa and in the rest of the world. And therefore, it's clear that greater partnerships between the public and private sector is going to be absolutely mission critical. To fight and flatten the coronavirus curve is an acid test for stakeholder capitalism and especially for multilaterals. And adapting a multi-stakeholder and multi-sectoral approach, therefore, to address women, children, and adolescent health is going to be absolutely critical. Such an approach enables the strengthening of national coordination, alignment, and accountability by building on existing efforts and avoiding duplication. So therefore, I'm looking forward to this discussion to engage with all of you, to look at what works best. From Kenya, we have a few examples, and that's why we have Jan Willem here. But before that, I would like to hand back the floor to Barbara onto the remaining part of the program. Barbara?
Wonderful. Let's hear from Jan now.
Yeah, thank you very much. Thanks for inviting me, for setting this up, Sid. So the private sector, yes, does have a place at the table, and it should be an essential part of the multi-sectoral national platforms. Unfortunately, the SDG 17s agree with that, that it should all be multi-sectoral. But in practice, what we're seeing is that, especially in healthcare, this is still a little bit difficult. And even though we align on purpose, and the private sector has fully embraced the SDGs and the goals of SDG 3 and the RMNCH goals, still there's a bit of friction. And why is that? Why is it so difficult to get the private sector engaged? Well, sometimes there's a lack of trust, and there's a sense that the private sector may have a conflict of interest. But I say, yes, there's a conflict of interest, but so does everybody have a conflict of interest. So let's be open about it and manage that. But there's also confusion about who should be sitting at the table, because the private sector is so huge and diverse and all over the place. So who do you get actually to represent the private sector? And while these are all good reasons to be careful, it's not a reason to not invite the private sector or exclude them, because I don't think exclusion is the solution to all this confusion. So what is the problem if you would not invite the private sector to the table? Now, in these times of rapid technological change, you see that the raft and the difference between the haves and the have-nots is getting wider. So the ones that have good access to quality care get better access to better care. And we see that because of the artificial intelligence, we see that because of telehealth, remote monitoring, genomics, all these advances are just giving people better access to better care. And those that have poor access to poor care are just left behind. And this is accelerated by COVID. And those that are left behind most are the women and children. So how do we close the gap? We can close the gap by making sure that the private sector also invests their innovations and their R&D budgets for those that are left behind. And there's no other way in which you can force that or can actually get that alignment of mission unless you are doing that within the context of a multi-sectoral and a national platform. And I really want to stress that point. You will not divert R&D for those that are left behind if you do not get the private sector at the table. That's why there's the issue. So while in pre-COVID times, the collaboration with the private sector was complicated, during COVID, suddenly everything was possible. Philips is a producer of ventilators and one of the biggest. And suddenly we were being invited by every government leader around the world. How can you help? How can you scale up? How can you innovate faster? What can we do for you to be more successful to help solve all our problems? And it was great. One person at the UN said, actually, during the crisis, that we've never worked with the private sector in a better way than during this crisis. And in fact, it was easier and faster to work with the private sector than with some of the governments. And so why we were so afraid of you before? What has stopped us from doing this? So I think hopefully there's a lesson for us to be drawn there. But while COVID helped accelerate that collaboration and the dialogue, we also saw that the danger of not having everybody around the table, like women and children, pushes us back into silo thinking. So during COVID, there was a razor sharp focus on just COVID. But we missed the other things. So I want to give you an example. One of the devices that is very often used during the COVID crisis is the ultrasound, just to inspect the lungs to see what damage there is to the lungs and to the heart. So when I asked, I said, well, are you going to purchase a configuration that will also be used for pregnant women? Because it's a slightly different configuration. I actually hadn't thought about that. I said, well, if we would all be at the table, I mean, through dialogue, we could solve this, but if everybody would have been at the table, we could have fixed a lot of these problems. And what I would like to invite everybody to consider is that developing countries are at the brink of spending enormous amounts of money on strengthening the health system in anticipation of the first wave or the second wave. The World Bank has made $14 billion available for that. So these decisions are being made now. Private sector is already at the table, but are the women and the children at the table? Are we all at the table to make sure that this health system strengthening just solves the COVID crisis, but also lies the foundation for better RMNCH? Now, that can be done in a multi-sectoral and a national platform like the ones that SID has set up in Kenya, where the idea was really to bring everybody around the table, private sector, the government, NGOs, and the academia, aligned on the same purpose, to improve, implement the SDGs as a first focus on primary healthcare and investment in $1 billion. And why did it work? Not only because of heroism, I said, and I hope it's going to be standardized, but also because the UN is a neutral broker. And everybody trusted the UN to be that neutral broker and to keep everybody honest. And because we left the country in charge, the ministry was in charge, and because everybody aligned around that common purpose and in their own roles. And while the dialogue is the best way forward, and these multinational, multi-sectoral forums are the best way forward, these dialogues may be a little bit uneasy at first, and sometimes create friction. But I say, without friction, no shine. Thank you.
Thank you so much. Now I'd like to invite the audience to go ahead and enter questions into the chat box that we have. And while we go through those, Sid, would you like to respond to Jan Willem's explanation of what you did in Kenya, and perhaps outline the best practices, but also some of the challenges you faced while you were doing this. Mute.
Okay, here we go. So, you know, John Donne once said that no man is an island, every man is a piece of the continent. And this I realized very quickly when I came to Kenya in 2014. And Kenya was amongst the 10 most dangerous places for a woman to give birth. I mean, the maternal mortality ratios were completely out of the kilt. Kenya did not achieve the MDG 5, which was about bringing maternal mortality ratios to less than 170 deaths per 100,000 live births. There were counties in Kenya which were at 3,795 deaths per 100,000 live births. So that was the challenge that was in front of us. So as a matter of fact, it was someone from Philips who walked into my office here in Nairobi and said, listen, you know, we would like to partner up and look at what we could do together in the space of RMNCH. I told him, we've identified 6 counties, which are pretty difficult, actually quite dangerous. And that's where the highest maternal mortality ratios are. And reluctantly, the Philips person who was there said, all right, okay, you know, we'll take a look at it, but I cannot make a commitment. And I arranged a flight where the private sector, government of Kenya, someone from the office of the president, civil society partners, the Kenya Red Cross, and we arranged that flight and landed there. And very interestingly, what we saw was we were caught probably in a time and space factor where perhaps we were in a 14th, 15th century setting where everything, and including the scourge of violence, cross-border terrorism, the scourge of female genital mutilation, early marriage, everything. It was a perfect storm of what made that county have a maternal mortality ratio of 3,795 deaths per 100,000 live births. But the First Lady of Kenya, Margaret Kenyatta, had what is called the Beyond Zero initiative, which was about accelerating the reduction of maternal mortality ratio in this country, which was moving up the economic ladder and yet was caught up in this very tragic issue of maternal deaths. So, and the national average was at about 488 deaths per 100,000 live births, which would give you a perspective of how bad the situation was. Anyway, bottom line, we were able to come together with Philips, with GlaxoSmithKline, with Safaricom, with Huawei, with Kenya Healthcare Federation and Merck, and we established a compact. And we said, listen, let's try and see if we can change the situation in these 6 counties. 2.5 years down the line, we were actually able to bring the maternal mortality ratios down by 1/3, and this was actually captured in a study which was done by Deloitte, and how we did it and the advocacy that went into it. But what it actually showed was how does public-private partnerships work at the ground level, and what does it take for the UN family, for civil society and governments to understand that as a matter of fact, this is where we can achieve scale and impact. So therefore, national ownership is absolutely critical, which means leadership of the government, but ownership by the government. The second part was we have to break down the silos, make it multi-sectoral and bring in all partners. Nobody is outside the table. The ecosystem approach of looking at reproductive maternal child health as the very vanguard of universal health coverage. And finally, it is how do we harness big data, technology, innovation to leapfrog this. And what this thing in the 6 counties showed us was it's possible to do it. But what it also brought was a committed group of leaders who really believe that, yes, we can change the game here. So what we showed in Kenya was a microcosm and perhaps a blueprint of what can potentially happen. It is about courage at the highest levels of saying, let's embrace this model, let's go to scale, and let's make sure that we can achieve not just the SDG goals, because the SDG goals are, of the first 5 goals are the unfinished business. So what we now need is to move that needle and to say, everybody belongs to the table, and let's now get on and flip the orthodoxy, which the Deputy Secretary General Amina Mohammed often reminds us of. And that's the direction with which we can actually go and change this paradigm. And this paradigm, we've proven it on the ground. Now it's about taking it to a model that is scalable. Thank you, Barbara. Over to you.
Thank you, Sid. So that tends to bring up the question about in these multi-sectoral approaches, specifically to Jan, how is Philips balancing profit versus making COVID-19 equipment available at affordable prices to LMIC? LMIC are also excluded from accessing those equipment and other commodities as rich countries buying them at requested prices. So how is Philips ensuring equity in this regards?
Yes, so in terms of pricing, let's make absolutely sure that Philips did not increase their prices, has kept their prices as, you know, for all of those markets where they are appropriately priced locally. And in fact, so the opposite happened to what happened in PPE, but because we can't and we wouldn't want to morally, but also people will, you know, our pricing is fairly transparent, so people know. And our reputation would be severely damaged if we do. So there are two reasons. We don't do it because morally we were not made of that. Secondly, there's public scrutiny that would prevent us from doing so in this market because we're such a big player. But what you absolutely identify a really important topic, that was access to this equipment. From the moment that this crisis broke out in China, we have been engaging with the WHO and with the World Bank and with the European Commission and others and said, everybody's going to fight over these products. How do you get fair allocation, fair and ethical allocations? And how can you guide us to tell us which countries go first? And how do we choose between, for example, Malawi and the Netherlands? Or how should we choose between the United States and Kenya? And that is not a question you should leave to us. Also, because we don't know, you know, where all the ventilators go. And we ask for a coordination and that neutral brokering at the global level. Where at the moment, to Sid's point, multilateralism is falling short. And we hope we will see a betterment of that. And while the mature markets were continuing to buy up all the equipment, we continue to have the discussion with the World Bank and the WHO and say, look, how do we make sure that equipment is also available to Africa, for example? And how do we make sure that even though the African countries did not place any orders, I mean, they're really running behind. We are now thinking about, okay, end of August, September, October, when the wave really hits Africa, how do we make sure that we can supply? We've even innovated and we said, look, in order to meet the demand of all those people that are going to fall sick and don't have professionals and nurses and doctors to care for them, can we reversely innovate and develop a really cheap ventilator, which we did within a period of 6 weeks, in collaboration with the UN system. So that's what I mean. If you talk about, so how do you get it around the table, identify the common problem, and then innovate in that area, then we can do that. And I think, you know, the Africa Union has put together a COVID team and engaged really well with the private sector. And I would like to see that happen more at a broader level. And I know that the African Union has said, look, we'll use this COVID crisis as a way to strengthen universal health coverage and therefore also RMNCH. But so far it's been conversation and not at the country level, not at the action level yet.
Thank you. I have a question from the audience for Sid. How can bilateral and multilateral organizations support national efforts to adopt a multi-stakeholder sectoral approach and facilitate its implementation during COVID-19 and post-COVID-19 to ensure better preparedness and build resilience to cope with future crises?
Thank you for that question, Barbara. And I think it's very important to understand that what COVID-19 has done, it was like a bolt of lightning, which came and opened up the contours of inequality, both intra and inter-country inequalities. And essentially, it brings back to the original statement that I started with of Herophilus and why the primacy of public health becomes so very crucial. You know, the concept of too big to fail has now been challenged. Who would have thought that John Maynard Keynes's economics of governments coming in to say, you know, to rescue companies is unthinkable? Who would have thought that the German government would invest in Lufthansa now to bail Lufthansa out? This was not part of the plan. And this is why bilaterally notions have to change, because we are as strong in our healthcare system as far as the weakest link is concerned. Who would have thought a virus in the eastern part of the world could come and impact the western part of the world? California is going into a second lockdown as an impact of the virus. So therefore, a bilateral discussion that needs to bring together everybody around the table, because everybody is needed on the table. Today, actually, entity-wise, that is, the people that are most affected are the private sector. They actually now have a stake in improved health outcomes because their workers are getting increasingly morbid as a result of the virus. They are losing businesses. People are getting sick, and suddenly profits have started to decline. Their GDPs have started to shrink all across the world. So it's probably that opportunity to now reawaken the whole spirit of multilateralism to impact public health. So if I now look at the 17 SDG goals, I think SDG 3 comes right up on top. Now, in order for SDG 3 to succeed, we have to get the primacy of reproductive, maternal, neonatal, and child and adolescent health right into the center of this conversation. Over to you.
Following up on that point, how are we working to ensure that this inclusivity, it includes the citizens and lets them lead the identification of these pressing issues to the table?
Well, that
maybe
is
I
why...
can
Go ahead. Sorry.
So I'd like to say something about that, because that comes to the point of where is this conversation taking place. And I've always been a little bit skeptical about the dialogues in New York and Geneva, with all respect to whoever is based there. But that's not where the change is going to happen. And that's why I've always been interested in the national dialogue. But it doesn't stop there, because I agree, even at the national dialogue, like in Kenya, in our SDG partnership platform where everybody is represented, it's very difficult to get the voice of that one is left behind. Now, clearly we have the UN there to keep reminding us about those that are left behind. And for example, UNFPA has been phenomenal. And that sets example to say, okay, I'll show you who's left behind, and take a plane to the most affected area and show us. It's always one step away from where the decisions are being made. So the dialogue is set multinational, yes, national starting to happen, but at the country level, the county level, at the community level, that's really, really important. So partners like AMREF that we work with, or Farm Access, try to really go deep down. And one thing that we did, for example, in Congo Brazzaville was UNFPA. When we tried to redesign RMNCH services, UNFPA took us right down to the community with all the stakeholders. It's like, this is where we're going to have 6 different co-create sessions in 6 different areas, far, far away from the capital. And that's where you start to see things that you will not see in the capital. So, I mean, you know about them, but they're kind of implicit. And one of the examples that struck me was, we had designed a fantastic healthcare system. The doctors were excited, and the nurses, everybody, the NGOs, everybody was excited. And UNFPA said, well, there's a massive pygmy population living out here. How they've been discriminated. They don't have access to the hospitals. I mean, geographically they have access, but they just don't go there. So how do we amend for that left behind population? And until you're there, you will not design those solutions. So multi-sectoral collaboration, yes, it has continuously left out the most important stakeholders, yes. And you can only do that by moving the dialogue and the multi-sectoral dialogue into the community. And that's going to be the hardest part. But the moment we show that it works, I'm sure we can find a way to replicate it.
Thank you. Sid, do you have something more to add to that?
I mean, the fundamental nature of civil society is going to be even more crucial now. And the UN really needs to become champions of civil society. We've generally tended to be too much the pro-government focus, which is very important. But the UN can actually act as a bridge of bringing civil society to the table, frankly. The program that we launched with Philips and the other companies that I mentioned in northeastern Kenya would not have been possible if we did not have the Kenya Red Cross, if we did not have other civil society organizations working in lockstep with us. And I think, here is where the opportunity really lies. I see profits as a good thing. I don't see it as a problem, because if there are no profits, how do you make it sustainable, and how do you make more research happen? And therefore, recently we actually undertook a visit to the Silicon Valley, the Minister of ICT and Youth and the UN team. And we found there were several Silicon Valley companies really interested on how they could offer their technology and innovation in order to accelerate universal health coverage, and with a particular focus on sexual reproductive health and rights. That conversation is happening. It's a matter of how do we galvanize it. And that galvanization, as I wrote in the chat box, needs a mindset change. That mindset changes till such time, all the way from Dr. Tedros down the chain of command in WHO, they understand that if we don't embrace the private sector, if we don't bring in other civil society partners, we will not achieve the 2030 agenda in this decade of action, because what COVID-19 has done is challenged us. It's challenged science, it's challenged technology, it's challenged how vaccines are going to be manufactured. It's unpredictable, it's mutating, and it's really put us on our toes. Do we come out better? That's the opportunity we have in front of us. And I hope this event therefore drives that kind of systemic change that we need in mindsets. Over to you.
Wonderful. We have a comment from the audience. Why does collaboration always think curative is the way? Prevention and promotion would be much cheaper and faster. Without it, SDG 3 is unreachable. Sid?
Well, as I said at the very beginning, suddenly SDG 3 has gone up in the priority list. And look, even from the preventative side is the key side. If you look at Western Europe, if you look at the Americas, if you look at the Asian tigers, what they succeeded in was on the prevention side. Jan Willem actually comes from a country which had actually seen the scourge of malnutrition. If you've heard of the Dutch winter, you'd probably know that, you know, they were cut off, and an entire country which is malnourished because food was not allowed to come there. But what Western Europe did post Second World War, or what the Americas did, or the Asian tigers did, was they corrected the imbalance of universal health coverage and made sure the primacy of public health was there, which meant making sure people were immunized, making sure reproductive maternal child health were in the right place. And as a result, society started to grow. And that is why the primacy of prevention becomes even more mission critical today. Because if we don't prevent, we are sitting ducks for the next pandemic to strike us. And therefore, you know, completely agree. And for the private sector, there is a stake. For insurance companies, there's a stake. For companies such as Jan Willems and everybody else, there's a stake on the prevention side, because they are impacted by the curative side, just as we are seeing how health facilities and what I term as the big five from this part of the world, which is the US, the UK, you know, France, Italy, and Spain, that have been so badly affected by this pandemic and upended their health systems. Over to you.
Thank you. Following the comment on COVID's impact, how do you see the trajectory of universal health care, Sid? I mean, do you feel that it will start coming into being more universally? Okay.
I mean, you know, any sensible political leader would know by now that they don't get universal health coverage like they probably, in a democracy, they have no chance of coming back again. And it is absolutely, it's abundantly clear that here is one invisible, virulent, high velocity virus that has really taken our most advanced scientific minds and challenged us. So I just think that this is the time for the whole spirit of multilateralism. And that's why I speak up constantly, and I'll reiterate again, we need a stronger, we need a much more powerful WHO under the leadership of Dr. Tedros to be able to do just that. And I think the entire UN system now needs to revisit some of our systemic priorities and putting health, and because health is not just the curative side, the preventative side, the education that accompanies it, the entire value chain that needs to accompany it. I think that becomes so much more important. Where it's very clear. If you look at countries which are under stress, they have very, very high total fertility rates. If you see countries which have very good health systems, their total fertility rates are down. How do you achieve a demographic dividend? Is by a balanced, well-articulated total fertility rate. And that's where the symbiotic kinship of reproductive health and rights is therefore become even more paramount. Nothing can challenge that, not any longer. Over to you.
Thank you. Jan, do you have a perspective on how the private sector views universal health care?
Yes, well, I mean, I've always seen universal health care coverage as the umbrella for all the vertical interventions. What we've seen so far is that the focus on verticalism of donors, of governments, of stakeholders has made it impossible for us to see the whole picture. And what COVID did is that, of course, everybody suddenly started to focus on COVID, its patients, but it also shut down physically the rest of the care system. Mm-hmm. And now everybody is understanding that, okay, maybe that was not such a clever idea. And if we're going to have to live with this and the next pandemic, how do we make sure that we address all parts of the healthcare system and all needs? And even though I've been saying this before, COVID made this really, really clear, because so many people died of cancer or cardiovascular disease, or mothers. I mean, we knew this because during Ebola, we knew that the ones that suffered most were the women that were having to deliver babies and were not allowed to go into the hospital and had to deliver at home and died because of complications. So we knew that this was going to happen when a pandemic hits. And somehow, because it came close to our homes everywhere around the world, now suddenly we see that. So, so this silo thinking, this focus on one issue and trying to ignore the other issues doesn't work. And in fact, you get riots and upheaval around the world, even in the Netherlands on the streets. Our healthcare doesn't work. I want to go back and give me my right to my healthcare and whatever it is, and mothers and children, of course, included. Now, I do think that we can change it, but if I talk to government leaders, if I talk to the OECD, so we're talking about mature markets, and I ask, how are we going to restart the health system? What are we going to do? Are we going to have two parallel systems? How are we going to finance it? Are we going to do everything together? People have no idea. So it is as if we're rebuilding a healthcare system from scratch. Now that's disastrous and fantastic at the same time, because it gives us the opportunity to go back to the drawing board and say, okay, what did we do wrong in the past again? So yes, the side of thinking. So now we all know that doesn't work anymore. So to rebuild the healthcare system the way it was before COVID, everybody agrees that's not going to happen. That's not going to work. So there's a beautiful opportunity to reset. Now the question is, if you're going to reset your health system and rebuild it again, are you then at the table to help design the healthcare system? And mother and child care is one of those healthcare needs that's longitudinal. You can't just do one intervention of immunization and skip the rest, or the antenatal care. It's longitudinal, just like cardiovascular disease, like oncology disease. And I think it was primarily the longitudinal nature of mother and child care that was its risk. It's the fact that it wasn't invested in, because it took such a long time to get a child healthy, in a lifetime. But technology now allows us to look at longitudinal interventions, look at outcomes over 10, 20 years. And we are seeing that healthcare systems are starting to remunerate and start to incentivize longitudinal approaches towards healthcare. So RMNCH as well, just like cardiology and oncology, are in the same shape. So that means that RMNCH can benefit from the technology that is now being applied to non-communicable diseases and lifetime diseases, because it actually are the same kind of thinking and same kind of reimbursement that will drive that. And it will also drive, just like with cardiology and oncology, move towards preventative action, which are so important in RMNCH, which are so undershadowed, but are now being strengthened, and we start to understand better why it's so important, thanks to oncology and cardiology, and thanks to all the mistakes we made during COVID.
Wonderful. From the audience, Jan, how do we make governments act on data, making sure that it is robust and correct data, and then appropriate services built on it? Governments are often self-serving with an eye to the next election.
Yeah. Well, I was almost going to give this to Sid, but I'll tell you how it works for the private sector, because I think this is where independent monitoring and evaluation and independent oversight, also at the government level, if the voters cannot provide that independent oversight, or the parliament, then we need to rely on multilateralism. But for the private sector, it works like this. We are increasingly looking at long-term partnerships and long-term contracts based on performance-based contracts and outcomes. And if we are going to be reimbursed or paid depending on the outcomes that we're going to achieve, we need to have robust data. So it is for the interest of the private sector and the interest of solution thinking and long-term partnerships that you agree on a data set that everybody trusts, and that the ones who are collecting the data are trusted, and that the way we process the data is also trusted and transparent. Blockchain has been used as a way to say that's going to revolutionize healthcare because nobody can tamper with the data and everybody will trust it. Yes, that's true, and there are other ways as well. But I really believe that data transformation, like we're seeing in Rwanda, for example, being used a lot, and the transparency about how the governance on the data will accelerate the transformation of healthcare, and the private sector will be taking risks because if the data is there that we were not able to take before, and that will actually put in investments.
Thank you. Sid, do you have a comment to add to this?
Well, I would just agree with Jan Willem there, and I think data must inform decision making, and this is where there is a critical role. This is why the UN Secretary General has pushed for UN reforms to make the UN fit for purpose. And being fit for purpose is having the intellectual caliber to be able to take the data and influence policymakers. You know, Barbara, there are 3 P's that are very, very important for the UN system to be absolutely on top of. Number 1 is to enhance and encourage political will. That's number 1. That's going to be absolutely critical. The second is to work with governments to come up with the best public policy fit for purpose for that particular country. And number 3, the UN must act as a convener, a connector, and a catalyzer of these different sorts of partnerships in order to have that scale and impact. Over to you.
Wonderful, thank you. Jan, we have about 5 minutes left. Do you have some additional comments that you were not able to present that you would like to?
Well, maybe a question back to the audience. So there are about 40 people, 37 people in the audience. And I would imagine that when you go back to your home office tomorrow, or you are already in your home office, of course, you ask yourself the question, so what am I doing in terms of multinational and multi-sectoral platforms? When you're going in your home environment, am I part of a multi-sectoral platform or am I not? Am I part of a platform that does not include the private sector? And why not? And do you have a neutral broker like a WHO or a UN? Or do you trust the partners that are around the table? And I'd like to challenge those people. Maybe here some of the audience have such partnerships. But I think it starts with awareness. Are you in platforms? Are you influencing through multi-sectoral national platforms? Or are you a lone wolf trying to hope to make a real big impact? And if you're on your own, maybe you should team up.
So please share with us some of your experiences in the chat. And while we wait for some of that information to come back, Sid, are there any pieces of information you'd like to share in addition to what you presented earlier?
So I would say leadership, and leadership at all levels of the UN family, civil society, governments, and the private sector. And it is not about being afraid of taking risks. And I think we should be risk takers and exploring new frontiers. It is key in order to truly realize the potential of the 21st century. SDG partnerships, the government of Kenya, my UN country team, as well as the leadership of the private sector, people like Jan Willem, as for example, other companies like MSD, Merck, AstraZeneca, Unilever, Safaricom, who have for years now taken a very strong stance and offered strategic guidance on how to advance our journey for impact. So as a result, we've been able to build partnerships models with the public as well as the private sector. So I would conclude by saying that we are living in a day and age, Barbara, where we have the expertise, the technology, and the means to advance everybody's health and well-being. It is our moral obligation to support Kenya and the rest of the world in forging partnerships to find the right modalities to harness the potential which is out there and make it work for everyone. That is why universal health coverage is called universal. And I think this is that moment that COVID-19 has lit up in front of us to really come together and go for scale and impact. Over
Wonderful. Do you have any best practices on how we can encourage documentation of what has worked and what has worked well and what hasn't worked, so that we can be prepared for the next pandemic and even prop up the universal healthcare coverage initiative that we need to pursue?
Would Jan Willem want to answer that? Or I could come to it after that.
Yeah, no, I saw the question and I was trying to figure out how to answer that one. It's very good to collect the best practices, and the best practices, everybody will step up and say that they're best practice. But the worst practices is more complicated. And but I agree that needs to be shared. And I think there may be a role for PMNCH to do that because they can operate as a trusted partner. They are trusted by the partners in in the entire ecosystem, and go out and study what did not work. It will probably have to be anonymous because I can tell you exactly all the things I did that did not work, but I'm not quite sure if I want my name attached to it in the public. And I think a lot of people will be like, I'm not that courageous. I'm very courageous, but not that courageous. So I think I'm happy to share that, and I'm happy to share it with somebody I trust, and I'm happy to that person that trusted then shares it with everybody else, so we can have a debate about it, and then we become like the Alcoholics Anonymous club of RMNCH implementation failures.
Great, thank you, Sid. Do you have any last comments, and then we'll return to the.
I would just reinforce the point that Jan Willem made. I think this partnership on maternal and child health, is also led by two incredible women who I have great admiration for, Helen Clark and Helga Forstead. I think we have an opportunity now to really bring the whole issue, and this follows up on the International Conference on Population Development recently co-hosted by the Kenyan government, UNFPA, and the Danish government. Really, this is now the time to push this particular agenda, which is also seeing challenges, Barbara. Don't forget, there are many countries where we are seeing a rollback on sexual reproductive health and rights, many countries that don't want to see the language of sexual reproductive health and rights featured in documents. And I think we need to challenge that. This is that moment to come together with the kind of leadership that we have and the platform that we have in PMNCH to bring all relevant stakeholders together, the UN system, the private sector, the civil society, and really start moving this particular agenda, because till such time we ignore the primacy of sexual reproductive health and rights, we will never achieve universal health coverage.
Wonderful. Thank you both for your information today. Jan, if you would like to head on back to the main plenary. And in the chat, we are giving the rest of you the link to the main plenary if you'd like to join and hear the headlines from all of the groups that have just been participating. Thank you so much again, Sid, and everyone for joining us.
Pleasure.